Good evening, everybody, and welcome to the 9th session of the Kolkata Anesthesia Academy, Apollo Gleneagles Hospitals, and the HCP Education Forum web-based lecture series on anesthesia. It's a pleasure and privilege in having you. What we will do is, before, ask you to put in your questions into the chat box. And at the end of it, we will scan through it, and whatever are the questions, we will take it at the end of both the presentations. And if you don't like the shirt that I'm wearing or the slides that I'm showing, please feel free to comment on that as well. We entertain those kind of comments. We are very, very liberal. All right, so this is about anesthesia in a patient with end-stage renal disease and dialysis. And we know, again, I think this is needless to say, somebody who has end-stage kidney disease, somebody who's on dialysis and undergoing a surgical procedure, the perioperative mortality morbidities are much more if they did not have any ASKD. And one of the classic referred is this 1,157 patients who underwent major surgery like abdominal aortic aneurysm. The perioperative mortality for undergoing open repair was 16%, 10% with an endoscopic repair. And this is much, possibly 4 or 5 times higher than the normal expected morbidity mortality rates are. And why is this so? It is essentially the classic combination of a person with end-stage kidney disease also having coronary artery disease, some kind of an LV dysfunction, the thin balance about perioperative fluid management, electrolyte imbalance in the perioperative period, especially hyperkalemia. We'll spend a lot of time on hyperkalemia. Their association with bleeding diathesis, bleeding complications, the challenge about controlling blood pressure, and both, and they are so labile. So the autonomic things that go wrong with these kind of patients is kind of the reason. They have an innate higher need of vasopressors as well as antihypertensives than the population without ASKD, and they have much likelier to go on a mechanical ventilator in the perioperative period, and their length of stay in the ICU, if they reach the ICU, also in the hospitals, are higher. So what I will take you through, hopefully within the next 45-50 minutes, is define CKD, or as well as end-stage renal disease, end-stage kidney disease. We'll spend some time about dialysis and about the types, the concerns, especially the things that are related to anesthesia. Comorbid associations, I'll pick and choose a few, not go through everything. Cardiovascular system is something which bothers us. Coagulopathy bothers us. Anemia bothers us a lot. Diabetes, of course. And then just nuggets about the perioperative management. As usual, we'll start with the poll questions. And Jyoti, Arnav, if you're ready, we can just put in the poll questions, please.
Yes, sir.
So again, like before, if you have been here before, there is this question, and you will have 4 options to those. All you have to do is pick the most appropriate option. And again, it doesn't matter. It's not an examination. It's just to kind of make you also involved with this. Otherwise, in these days of webinars, it's very difficult because I'm not able to see you. You can't see me. Whatever. So a 55-year-old end-stage kidney disease on twice-a-week hemodialysis is posted for a gallbladder surgery. So what should be the preferred plan? Admit the patient on the morning of surgery, check the potassium. If it is less than 5.5, proceed for surgery. Or admit on the morning of surgery, dialyze without heparin, check the potassium, if it is 5.5, and then proceed for surgery. Or is it admit the day prior to surgery, dialyze, check potassium less than 5.5, proceed for surgery the next day? Or admit the day prior to surgery, dialyze without heparin, check potassium less than 5.5, and proceed for surgery the next day. What I would be looking for, or what is the most appropriate It's not that you cannot do either of them, but what would be, in your opinion, the most appropriate way to get around this scenario? So please put in whether it is 1, 2, 3, or 4, and we'll close the poll in 5, 4, 3, 2, 1, and 0, and go to the next poll. And this is very straightforward. Which of the following is not true for peritoneal dialysis? Peritoneal dialysis cycle should continue as far as possible till the initiation of surgery. The dialysate should be drained prior to surgery. The drainage of the dialysate leads to an hyperglycemic response. And peritoneal dialysis does not need heparin, which is not true. Dialysis should continue as far as possible till the initiation of surgery. Before surgery, the dialysate should be drained. The drainage of the dialysate leads to hyperglycemia. Heparinization is not needed in peritoneal dialysis. I think this is straightforward. 5, 4, 3, 2, 1, and 0. And we'll go to the next poll. Okay, the third poll is a 68-year-old female, end-stage kidney disease on dialysis, BMI is 32, has got reflex esophageal disorder. Her hemoglobin is 11.5, potassium is 5.9, and ECG shows peaked T waves. She's been posted for a laparotomy for intestinal obstruction. Okay, and so obviously this is kind of emergency. You don't have much time. So you need to intubate the trachea. So what will be your preferred neuromuscular blocking agent for intubating the trachea in this lady? BMI 32, gastroesophageal reflux disorder, potassium 5.9, ECG peaked T waves. So your relaxant of choice to intubate the trachea would be succinylcholine, rocuronium, atracurium, or cisatracurium. Again, this is very straightforward. All you have to do is pick up which one do you think is the most preferred neuromuscular blocking agent. Kidney disease, BMI 32, reflux disorder, potassium 5.9, peaked T waves, laparotomy for intestinal obstruction. We'll close the poll in 5, 4, 3, 2, 1, and 0. And go to the next poll question. Okay. A 65-year-old female, end-stage kidney disease on dialysis, needs urgent obstructive hernia surgery. So it's urgent. So you have to kind of get in within the next 6 to 12 hours. On examination, you find that her AV fistula access site is oozing. So she has manifestations of bleeding, and she's end-stage kidney disease, is on dialysis, and needs an urgent surgery. So for the bleeding manifestation, or to control the bleeding, or to take management of bleeding, what would be your preferred approach? Dialyze without heparin, give desmopressin, cryoprecipitate, and platelet, or would be dialyze, desmopressin, cryoprecipitate, and fresh frozen plasma. Dialyze without heparin, desmopressin, cryoprecipitate, and protamine. Dialyze without heparin, erythropoietin, cryoprecipitate, and platelet. So essentially what we are looking at, this is a patient with end-stage kidney disease needing an urgent surgery, emergency surgery. You find that the AV fistula access site is oozing. So there is a bleeding manifestation somewhere over there. And how would you take care of the bleeding? And you have to go in for the surgery very, very quickly. Heparin, without heparin dialysis, desmopressin CPP platelet, dialyze, desmopressin CPP FFP, dialyze without heparin, desmopressin CPP protamine, dialyze without heparin, erythropoietin CPP plus platelet. So which is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0 and go to the last poll question of the evening. Okay. This is again 69-year-old, needs a non-urgent hernia surgery. Okay, it's not an obstructive hernia or a strangulated hernia. She needs a hernia surgery. You find that her hemoglobin is 7.1. On investigation, she is not iron deficiency. She does not have coronary artery disease. So what would you prefer to do in this scenario? Would you admit the patient, transfuse 2 units of PRBC and proceed for surgery? Admit the patient, transfuse 2 units of PRBC, 2 units of FFP, 2 units of platelets, and then proceed for surgery? Or would you hold surgery, administer erythropoiesis stimulating agent? I'm sorry about this spelling of erythropoiesis. We're too much in love with erythropoietin and erythrocytes, and this extra E's appeared over there. We target a hemoglobin of 10 to 11 and then admit for surgery. Or is it hold surgery, administer the ESAs, target hemoglobin greater than 13 and then admit for surgery? So it's essentially about how are you going to manage anemia in a patient with ESKD on dialysis, not iron deficient, no coronary artery disease. Preferred approach, is it just 2 units of PRBC and go ahead and do the surgery, or 2 units of PRBC, 2 units of FFP, 2 units of platelet, proceed for surgery? Or you say no surgery now, administer the ESAs, target the hemoglobin between 10 and 11 and then admit? Or you say no surgery now, give ESAs, target the hemoglobin around greater than 13 and then admit for surgery? So what do you think is the most appropriate response? We'll close the poll in 5, 4, 3, 2, 1, and 0. So thank you for participating. We'll get back to the answers at the very end, and we'll just tell you about, as I said, the first agenda is to kind of, especially since this is a target for the postgraduate students, there will be something which will be a little boring for the practitioners, I think. So CKD, or chronic kidney disease, is a group of disorders which there is an alteration in both the structure of the kidney as well as its function. And it can have various manifestations. The operative word again is that it should be there for more than 3 months. So then is when you called not AKI or acute kidney injury, but a chronic kidney disease. The term the end stage renal disease or kidney disease refers to a chronic kidney failure which then needs dialysis or transplantation. We'll go back to this a little more, and this is just a slide to show the gradual progression. Essentially, if you can screen the risk factor, modify the risk factor, then you possibly can prevent the damage and these complications. And if you can work on it, if you can diagnose early, slow down the progression, you can possibly decrease the decrease in GFR and the attending kidney failure, which has a very bad prognosis. So this is the spectrum of the disease. Just a few things. There's most of all these things, these chronic kidney disease, the definitions of end stage renal disease, the definition of when does it become stage 5 or what to do, comes from basically these organizations like the National Kidney Foundation, the Kidney Disease Outcomes Quality Initiative, and the Kidney Disease Improving Global Outcomes. The KDIGO is possibly the most looked at. They came out, their last, I think, thing was in 2009, to the best of my knowledge. The staging is by the disease, and essentially, I think the second part is the category of the glomerular filtration rate, which puts them into what stage they are. And the people have added albuminuria along with it, and that's where you add A1, A2, A3. GFR is the one that all of you would look at, and this is again for postgraduates. Few things. Don't worry if I'm running fast, as you all know by this time, and if you don't know, I'll just say it again, that these slides will be available in its entirety at the eduhcp.forum. So maybe after today is Friday, by Sunday for sure they will be available on the website, so you can go back to them and revisit things if you think you have missed it. So the normal is 125 ml per minute per 1.73 meters square. And when it becomes less than 15, you say it is kidney failure. And we'll just take you through the stages. Above 90 G1, it is normal or high. And it is between 60 to 90 that you say it is mildly decreased. And between 30 to 60, it is mild to moderate to severely decreased. Less than 30 but greater than 15 is severely decreased. And the end stage or kidney failure is when it becomes less than 15. So just to put it into perspective, this is an important slide, especially for the postgraduates, to figure out how do you classify based upon the GFR as to the stage of kidney disease. The other one is the stages of albuminuria, and this is the albumin extraction ratio. And again, this is very theoretical, and this helps in essentially classifying how much it has bearing on anesthetic management. I'm not very sure, but it definitely would have kind of implication on the prognostication. Duration is again that 6 months, as I told you before, to differentiate it from acute kidney injury. And this in one slide will try and tell you what are the structural damages and the functional problems that you have with kidney. I kind of find it easy if I break it down into the anatomical parts, and then it changes. Is it a glomerular disease? Is it a vascular disease? Is it a tubulointerstitial disease, or is it a cystic disease? And you'll find that what is causing this, like something like a systemic disease like diabetes, autoimmune, or a systemic infection will cause glomerular disease. A vascular component causes renal damage, things like hypertension, ischemia, microangiopathies. And the tubulointerstitials are classic urinary tract infections, stones, drug toxicity can cause. And then the commonest polycystic cystic disease is the polycystic kidney disease. And even in this day and age, the easiest way of diagnosing the type of kidney problem or the pathophysiology is by looking at the urine. And RBC cast, WBC cast, or the fat bodies or the granular cast gives you a clue as to what is the pathophysiological changes that are happening. So that was about definitions. I'll come to the preoperative evaluation. If you look at the preoperative evaluation, a lot of it will be similar. Physical examination, general lab investigations. What is special would be that try and figure out, is the person on dialysis? What kind of dialysis? Hemodialysis or peritoneal dialysis? What was the reason why they initially went into dialysis? Was it electrolyte problem, volume problem, metabolic problem? And along with it, the evaluation will necessarily mean comorbid status. What is the state of anemia, nutrition, but focus on the cardiovascular disease. This is what I would try and do now. Bleeding diathesis and glycemic control. Lab, I think it will be kind of similar. More emphasis on electrolyte values, glucose, blood urea, nitrogen, creatinine, calcium, phosphorus, magnesium, more for a nephrologist, maybe a little less for us. blood count, coagulation profile becomes very, very important, and kind of can guide you as to when you need. Phosphorus, the nephrologists are very, very particular about it, and because the way of managing the dialysis is greatly dictated by that. I am not very sure as to how much of implication it has for us. Do you need to do more above this? I think that it will have to be necessarily individually decided and determined. The one thing that I would possibly stress upon, that especially if they're on dialysis and you have things like digoxin or certain anti-epileptic drugs where there is a narrow therapeutic index, or something like maybe even warfarin, some people would say that it may not be a bad idea to look at drug concentrations at a periodic level, even prior to a particular procedure. This, I think, is special, unique for this group of patients who come in for a surgery, is the assessment of the axis. Figure out, especially if it is hemodialysis, where is it happening? Does the person have a perm cut into the neck, or does it have something into the subclavian? Does he or she has a fistula? Where is the fistula? Is it in the cephalic area, or is it in the antecubital area? So please figure out whether the fistula looks okay. There is no signs of infection over there. It's not oozing, as I think we saw in one of the poll questions. Mark it out, and because you need to take care of it when the person is anesthetized as well. So coming to dialysis, I think this is something of an approach that I have developed, or rather we have developed in our institution. Is like, first is, why was the dialysis needed? What is the type of dialysis the person is on? Has the dialysis been efficient? What markers am I looking at it? And then I think this part, the last three, becomes very crucial, is the timing of dialysis. If it is an elective surgery, when should ideally the dialysis be done? If it is an emergency surgery, do you still have a time to do the dialysis? Or has the dialysis been done and then subsequently the person needs to be wheeled into the operating room? And there could be things like a medical emergency, like an elevated potassium values, or an elevated or a bleeding diathesis that you think is happening, and dialysis is going to take place or should take place, and the surgery is to happen as well. So these are the issues that we need to actually delve upon before we embark. Why was it needed? As I said, it would be because of these reasons. Volume is possibly the greatest thing, most common indication. Rising urea, rising creatinine, and acid-base disorder and electrolyte values. And acidosis, that renal tubular acidosis, and hyperkalemia could be the main reason. So what was the reason? If you can try and figure out what type of dialysis, it will be either hemodialysis and peritoneal dialysis. And if it is so, how frequently does it happen? Because that you will figure out has to match with the timing of surgery. And peritoneal dialysis, is it a continuous ambulatory one, or is it periodic ones? And again, what are the cycles, and what is the dialysate, and how much? And try and figure out that you have to take care of the dialysate before the person comes into the operating room. Not exactly dialysis. You might have patients on this CRRTs, as you said, the renal replacement. Classically, this is like a filter, not dialysis, and I'm tried and removed it from the purview of this discussion. And it is unlikely, unless the person is in extremis, that a person with on CRRT is going to come into the operating room, is likely to stay in the ICU, because the person has been unstable, that is not being dialyzed and is on CRRT. So this is the timing, and this is, I think, very important. It should be either the day or the night before the day of the procedure. So if the surgery is planned at say 8 a.m. in the morning tomorrow, this is the best time possibly for the dialysis to happen. The platelet functions, the metabolic milieu, the fluid status are possibly at its best within that window of, many call the 8 to 24-hour window. So that is possibly the best time when the dialysis should happen before a planned procedure. Peritoneal dialysis generally performed until just prior to the procedure, and the dialysate should be drained prior to the procedure. So this is the two things about peritoneal dialysis, and one important thing about hemodialysis. Efficiency of dialysis: nephrologists look at the target weight, and if they attain the target weight, they say that the guy is doing well. But be careful about, and they only tell you that unless there is a reason why he's losing weight, like maybe it's a malignancy or malnutrition or whatever, we look at it more at the angle from urea, creatinine, and electrolytes, and possibly the pH, to look at the efficiency of dialysis. So a person on dialysis, you know the potassium values, and how do you decide that you can proceed or when not to proceed? Unfortunately, no specific guidelines, but I've kind of will give you a rough guide as to what should be done. So to proceed or not to proceed, vis-a-vis hyperkalemia, there are a few things that needs to be taken into account. What is the urgency of surgery? Can the surgery wait for 3 to 4 hours or possibly a little more, or 6 hours? Is there a way that I can fit in a dialysis for a couple of hours at least and then take the person up? Because a couple of hours is enough to correct potassium at least through a dialysis. How much is the likely tissue damage that I am expecting? And therefore, then if I am expecting a huge amount of tissue damage and huge amount of release of potassium, my threshold for accepting a particular potassium value will be lower. What is the anticipated blood loss and fluid shifts? Again, that this is again in consultation with your nephrologist and your surgeon. You decide as to how much that you don't want the person to get negative on the dialysis. And am I expecting an impending acid-base disorder, and then and do I have the time to get this person to dialysis? So these are the factors that should be borne in mind. So to solve the potassium conundrum, we throw another hat in the ring, is the role of the ECG. And we know that the potassium, how it influences the ECG is not by the absolute serum potassium value, but the transcellular potassium gradient. And this hyperkalemia induced depolarization of the resting membrane potential is what leads to inactivation of the sodium channels, and therefore a decreased membrane excitability. So whatever ECG changes that you see is because of the transcellular potassium gradient depolarizing the resting membrane potential and inactivating the sodium channels and decreased membrane excitability. The kind of consensus opinions that occur is that it's the transcellular gradient, and it is not the absolute serum potassium values, and there it is essentially because these patients inherently have a higher total body and intracellular potassiums, and therefore unless the serum potassium goes to around 6 or 6.5, that you will not see ECG changes. There are two things that are disturbing in this, is that the ECG changes are not always orderly, that yes, at 7 I see this, at 8 I see this, what is classically taught in textbooks. And you might have no changes, but a sudden cardiac arrest with an hyperkalemia also happening, reported. So just be careful about this. This is, I think, we'll see in all textbooks. What are the ECG changes? Tall peak T waves when it is between 5.5 and 6.5. Loss of P waves happen around 6.5 to 7.5. Between 7 and 8 is the widening of QRS. And above 8, you get arrhythmias and asystole. And students, if you want to get into this, please come back and look at this at the Edu Forum and figure out what the changes are. So this, I think, is the answer everybody looks for. What is that potassium value at which I say, yes, go ahead for surgery? Or what is that potassium value at which I say, no, surgery cannot be done? I think we come to this. This is that 5.5 milliequivalent per liter. This is the high normal value. For elective surgery, induction with a value less than 5.5 is generally reasonable. What will happen if it is 5.5? Ideally, dialyze the patient. And as I said, unlike a full 4-hour cycle, 2 to 3 hours of an hemodialysis will typically suffice to prepare a patient for surgery. So this is about the ideal potassium value, elective surgery. But if it is not an elective surgery, if it's an emergency surgery and you find that the potassium is 5.5, ECG, there is no change. Again, this is again from the consensus opinion that have been arrived at, that you can proceed with surgery in this scenario with a continuous intraoperative ECG monitoring, and you should have the ability to measure potassium values at very regular intervals, maybe every half hourly. So emergency surgery, you cannot take the person to dialysis. This is what you can do if you see that there is no ECG changes. If you find ECG changes, if feasible, dialyze. Again, for that 1 to 2 hours, which is enough to prepare the patient. What if you cannot dialyze? Then you will have to look at alternative temporizing medical management. So the potassium is above 5.5. You cannot dialyze. It's a life-saving, acute emergency, life-saving surgery, maybe for an hemorrhage, for a bleeding vessel that you need to go in right away. So if you have an ability to do it intraoperatively, a CRRT in that scenario, maybe, but temporizing medical management. And again, I will not spend much time on this. I'll just tell you what the temporizing methodologies are. But if you want to go again, come back and have a look at it at a later time. Medical management, temporary medical management is calcium, insulin, glucose insulin, or bicarbonate. I'll just pause here and say, why did I say temporizing management? It is because this will not remove potassium from the body. The potassium stays within the body. You are trying to send the potassium inside the cell and therefore change the transcellular gradient, or you are taking care of the membrane potential, and that is by an agent like calcium. So you are not sending the potassium out. The potassium is still inside, and this is why with medical management you will have to keep repeating. Calcium for hypercalcemia is IV calcium, calcium chloride 500 to 1000, and it directly antagonizes the cell membrane actions of hyperkalemia. This is how calcium would work. You can give gluconate or chloride. Chloride contains 3 times the concentration of elemental calcium, but chloride is very, very irritant. It's very unlikely that you can give chloride through a peripheral vein. You have to give it through a central line. So calcium gluconate, therefore, is the more preferred approach. How much you give it is 1000 milligrams. So 10 ml of a 10% solution if it is calcium gluconate. In chloride, you can start with 5 ml of a 10% solution. Continuous cardiac monitoring is crucial. And if the ECG changes persist, you can repeat this after 5 minutes, and you can keep repeating it. It begins within minutes, but is very short-lived, lasts for 30 to 60 minutes, and therefore, if you are managing with calcium, you'll have to give something else as well, whether it is glucose insulin or bicarbonate or diuretics, or think of other ways. but because this will come back to you. How about insulin glucose? This is, as I told you, drives the extracellular potassium into the cells and therefore is reducing the gradient. If the glucose levels are less than 250, give insulin and glucose. And the usual protocol that most people follow is 10 units of a regular insulin bolus shot, followed by 50 ml of 50% dextrose, essentially 25 grams of glucose. Follow it up by a 10% dextrose of 50 to 75 ml at 50 to 75 ml per hour. You will have to keep monitoring the blood glucose levels. That is absolutely essential. Again, this is an important slide. How do you manage hyperkalemia with the glucose insulin? And I think if you can't remember it, go back and have a look at it. But this is how it works and how much you need to give. And I said this is by enhancing the activity of the sodium potassium ATPase pump that it drives the potassium inside, especially the skeletal muscles. The effect begins within 10 to 20 minutes. It peaks around 30 to 60 minutes. And that's why repeated monitoring of potassium and glucose is essential. And it lasts a little longer for 4 to 6 hours. The potassium can drop by the regime that I told you, 10 units bolus, 25 grams glucose by around 0.5 to 1.2 milliequivalents per liter. This is an interesting trivia. Patients with renal failure are resistant to the glucose lowering effects of an insulin, whatever it be the reason, where resistance of the receptors, but the hypokalemic effect, they are not resistant because the sodium potassium ATPase activity is still enhanced. If the pH is low, then there is a cause in adding bicarbonate therapy at 1 to 2 milliequivalent per kg. It again drives the extracellular potassium into the cells and reduces the transcellular gradient. That was about temporarizing. How do you remove the potassium? The most efficient way is obviously the kidney itself. If the kidney is not functioning, then obviously it is dialysis. And then the others are diuretics and the cation exchangers. And this, to remember this, diuretics alone in an hyperkalemic emergencies will not be effective. You'll have to add something else with it because the kidney itself is not functioning. The other issue with dialysis is volume overload and fluids, because if there is a fluid overload and there is a pending surgery, if it's overloaded, this is, I think, very intuitive. They can run the risk of going into pulmonary edema, which was also a reason for them to get into dialysis itself. So an optimal volume status is very, very essential prior to surgery. And how do I decide? And this is where it's a multidisciplinary thing. Again, this is where your surgeons and an anesthetist input is extremely crucial to the nephrologist. If there is a huge anticipated fluid loss, they will not make it that negative. So what happens if there is this communication not happening and you do not reach the classic or the ideal volume status after a dialysis prior to surgery, or during surgery, the person receives too much of fluids? Remember that fluid clearance through their inherent kidney is not great at all. So they run the risk of going into an hypervolemic pulmonary edema status, and they then would possibly need an IPPV to just manage the pulmonary edema and an early return to dialysis, which is what is not removable. At the same time, if you remove too much of fluid, they will have hypotension. Anesthesia-induced systemic vasodilatation is the reason. And this is not desirable, especially if they have an arteriovenous access site, because severe dehydration can lead to thrombosis, we know, and these sites can get blocked. So the goal of dialysis is, am I reaching the target weight? Additional factors, as we talked about initially, potassium, urea, creatinine, and the pH getting into a normal range. Then comes the issue with heparin and dialysis, and you throw in surgery in between. If you are forced to do dialysis on the day of surgery, ideally it should be an heparin-free dialysis. If heparin has been given, it takes at least typically 4 hours after heparin termination that the coagulation factors start coming back to normal. So if you are pushed into, please do wait for that 4 hours before you get the person in for surgery. And peritoneal dialysis, we talked about this, does not need heparin administration. This is in a scenario, as I said, person has had dialysis, and immediately after dialysis, there is a scenario by which the person needs to be wheeled into the operating room. You cannot wait for 4 hours, 6 hours. The best way of then neutralizing heparin is nothing else other than protamine. So that was about dialysis. I will come to quickly about the comorbid status and how can you optimize. Anemia status. If the hemoglobin is low, they fare poorly. And if the hemoglobin is low, as we'll figure out, you will have to, just like in other patients for chronic anemia, you have an algorithm going and figure out what is the iron status. And if the iron status is low, give them iron. If the iron status becomes normal, give them the erythropoiesis stimulating agent, ipotins, alpha, or whatever. Because, as I said, untreated anemia in a patient with end-stage kidney disease has increasing mortality and disabling symptoms, more if they have to undergo a surgery. So you have to get the hemoglobin levels up. And so the symptom that the person has a symptomatic relief, as well as very, very important that this mitigates the need of a blood transfusion. PRBC transfusion, as you remember, because always think in mind, these are potential candidates for a renal transplant, and you don't want them to receive a kind of an antigenic insult. So if that is hemoglobin levels are less than 12, evaluate like you would do. Same plethora of studies, find out the iron levels, or is the person losing RBCs. And this, again, very busy slide. This is for postgraduates. Please come back and have a look at it. I won't bother my head to find out what is inside there. So the indications for an erythropoiesis stimulating agent is patient with a hemoglobin of less than 10 and is not iron deficient. Please, the way forward is to give a erythropoiesis stimulating agent. The few places where you cannot give is if you have a potentially curable malignancy or a history of stroke. The adverse effects of ESA is higher in this group. The target level of hemoglobin in a person with ESKD dialysis is between 10 and 11.5. Hemoglobin above 13 has been also found to be of as a bad prognostic marker, especially after a procedure. PRBC transfusion, easy way out. It immediately raises the hemoglobin levels. Why we do not want, as I said, if they're potential candidates for renal transplant, you do not want an immunological sensitization, plus the standard things, overloads, iron overload, fluid overload, transfusion reactions, infection. Few things that we bother about: hypertension. Now, hypertension could have led to this disease, or this disease could have led to hypertension. And the trick about this again needs your consultation with a nephrologist. If you think that this hypertension is due to volume overload, simple dialysis, reducing the volume in the body, can reduce the blood pressure. And if you get the desired target weight and you still find the hypertension, then definitely the need of an antihypertensive therapy is needed. If you need to do it quickly, these are the standard drugs which all of you would know. I think this is again a classic thing as to what blood pressure levels will you accept prior to even an elective surgery. I think this comes from, again, KDIGO, also comes from the ACCAHA, that you have no business in denying surgery if the diastolic blood pressure is less than 110 millimeter of mercury and the systolic blood pressure is less than 180. If only the diastolic greater than 110 or a systolic greater than 180 would you need to manipulate this, because these patients are used to a higher forward pressure flow for organ functioning, organ perfusion. There is a potential of harm if you suddenly start therapy to suddenly reduce the blood pressure. So please do not do it. Cardiovascular evaluation, it's about coronary disease and the LV dysfunction. 50% of these patients with ESKD and on dialysis will have this. The evaluation is just like what we had discussed during the cardiac evaluation by functional status, ECG, non-invasive testing, and finally, if needed, coronary angiogram, if you think that will change the way we manage. Other disorders are like things like venous thrombosis are more common, peripheral vascular disease is more common, cerebrovascular disease is more common, more likely to have pulmonary hypertension, more association with atrial fibrillation. What bothers us is also heart failure, and the heart failure is mainly could be due to fluid overload, manifests more if there is an attended left ventricular diastolic dysfunction. If there is a systolic dysfunction or a valvular heart disease, they can go into failure quickly. And this, I think, is important, unique to this group of individuals, that if they have an LV dysfunction and you add a fistula, you could commonly see that after a fistula surgery, they suddenly go into failure. And this is the reason, because this hyperdynamic circulation in a patient with LV dysfunction can throw them into heart failure. Signs, symptoms are the same. And unfortunately, one of the markers, like the natriuretic peptides, may not be very kind of informative, because there is a peptide, because it needs to be cleared by the kidney, and in a kidney disease they're not cleared, so they would have an elevated value. So what is the value for kidney disease? I tried to find, I could not. If somebody knows, please put it in the chat box. Bleeding diathesis. Uremic bleeding is a known entity in this group of patients, and you can have the marker could be, as I said, axis side, and that could tell you that they have a bleeding tendency. Why do they bleed? Because of these antiplatelet agents that they might be on because of the coronary disease. Uremia itself causes platelet dysfunction. They could be on anticoagulation because of their AF. Could be due to the residual heparin during dialysis. Anemia releases NO, which is also a platelet function inhibitor. What can you do when you think there is going to be uremic bleeding? Well, easiest is PRBC transfusion, but you're going to hold it. The drug of choice is desmopressin. IV, I don't think you would get it in our scenario. You would get the nasal drops, classically used for reducing in diabetes insipidus, but can be used for uremic bleeding as well. And then is cryoprecipitate. Dialysis helps. Many people would say that people on chronic dialysis, the benefit is lesser. If they have been heparinized, as I think this I've talked about, it takes around 4 hours for the coagulation factors to stabilize. And should we take a patient in for a dialysis immediately after surgery? I think the recommendations are that you do not do it because of this increased bleeding tendency, and you may not be able to figure out where they're bleeding if it's especially a cavity surgery. So try and shift the dialysis after around 48 hours. And if you are forced, then you have to do the heparin-free dialysis. The standard tests of coagulations are done, but what can tell you about the uremic diathesis is possibly tests of platelet function more than anything else. And platelet aggregometry is possibly the best test to look at. Not many institutions will have the ability to do it. Or the point of care tests like TEG and ROTEM can help you to understand what is going wrong and institute therapy that was. Again, for postgraduates, if you want to look at what are the platelet function tests, please come and revisit this particular slide and the next one. It could be a short note. So it's suspected bleeding dialysis, planned elective surgery. What do? I say it is the double D, dialysis and desmopressin, and wait for 24 hours after the dialysis and then go in. The best period, as I said, is that 8 to 24 hours. This is the essential information about desmopressin. The effect begins within 1 hour and lasts for 4 to 8 hours. So you have to give it just prior to the procedure. If suspect excessive bleeding, do not have time for dialysis, then the only thing that you can go towards is desmopressin. And if a dialysis had happened and the person comes in, then the only drug that you can then take recourse to is rotamine. Platelets can be given. You need possibly 1 apheresis units or 6 units of platelets. But the problem with the platelets, it will function for a brief period of time, because the circulating platelets will, again, because of the uremic changes, pathophysiology, those transfused platelets will also be subject to the same changes and will get dysfunctional. And this is again important to realize that platelet count therefore may be very high, but they could be still be having a platelet related coagulation dysfunction. Cryoprecipitate has been tried because they can receive this increased amount of factor VIII and the von Willebrand multimeters and increase the fibrinogen levels. So you can give cryoprecipitate. And if you are pushed to giving blood, then the best blood is the leukocyte reduced or the irradiated blood. Diabetes, like hypertension, it could be the cause which cause this end-stage kidney disease. When do you treat hyperglycemia? If it is above 180. And glucose intolerance, as I said, is a feature of uremia. And surgery because of the neuroendocrine stress response, impairment of insulin secretion can lead to an hyperglycemic response. 2 trivial facts, but remember, type 1 diabetes mellitus may be very brittle in a patient with ESKD than those without. A single unit of insulin can make these huge fluctuations, changes between 120. So be careful about the insulin that you're giving. Just the reverse, in type 2, they are more likely to have profound hypoglycemia, especially when they are fasting, because the oral hypoglycemics, remember, are working for a longer period of time. So when they are fasting, it may not be a bad idea that you run a small dextrose infusion into this group of patients. What happens with peritoneal dialysis and the glycemic response? The insulin requirements of peritoneal dialysis may change depending upon on what rate these exchanges are performed. The dialysate has a huge glycemic load. So, and we discussed that it should be continued and it should be drained prior to surgery. So when you are going to drain the surgery, this was the glycemic load. And this, once the drain, when your dialysate is removed, they can possibly go into a hypoglycemic response. So the glucose levels can suddenly fall after the dialysate has been removed for peritoneal dialysis. Other system, pleural effusion, pulmonary edema, gastroparesis has some bearings for us because of the reduced gastric emptying. Again, there could be inflammation of the upper GI tract and could be because of that the bleeding manifestations. Coming to the anesthetic management, pre-medication is about aspiration prophylaxis and anxiolysis. Just, I think, very, very theoretical about this sodium citrate, and because of the phosphate binders, you can have increased absorption maluminium. I think it's very theoretical. I think this is about all medications because of the decreased glomerular function, because of the decreased tubular function, because of the increased volume of distribution, because of the decreased protein binding. Most drugs would have an exaggerated response and have a prolonged response. The same will be with midazolam. Very important is vascular access, especially if they have a fistula in situ where the dialysis is happening and a hemodialysis catheter. So in that arm where there is a fistula, no venipuncture, no vascular access, except in a case of emergency, and you cannot find any other access, is done. Don't try to go and do it. Please call the technician in the dialysis ward. He or she will be much more efficient, and he will or she will not spoil that access, which you and I can. During the surgery, take care of it so that there is no inadvertent puncture or there is damage to that access at any point of time. Should I use a hemodialysis catheter for drug administration? The recommendations, I would say no. But again, if you are forced, you do not have any access, then you can take recourse to this. The general considerations, I talked about this, is same. It's about this, the drugs not getting excreted, drugs getting prolonged in the body. Is regional anesthesia useful in patients with ESKD? It can be, because it can reduce the potentially hazardous general anesthetics. The avoidance to administer multiple IV anesthetics are reduced, and it obviously produces superior analgesia, requires less of systemic analgesics, especially NSAIDs, which you are not able to give, so you give definitely superior quality of pain relief. The catch to this is, remember, they can have bleeding diathesis. Please do check the coagulations before you give anything. Residual anticoagulation after heparin administration will be there at least for 4 hours. And so if you're putting in an epidural, removing an epidural, the timing becomes very, very important. The other two things about local anesthetic is more theoretical. Induction agents, the preferred induction agent is propofol. The pharmacokinetic and pharmacodynamic response are not markedly altered. But if there is elderly, like a patient with failure, you will have to obviously decrease the dose. It's the same. Few words about muscle relaxants. Suxamethonium remains the drug of choice for rapid sequence induction intubation. Remember, the risk of aspiration is higher. It is safe as long as the potassium is less than 5.5 and there are no ECG changes. The increase, like in a healthy individual, is around 0.5 to 1. And because of the decreased plasma cholinesterase, the duration of action of SCH will be higher. So now you have a potassium which is more than 5.5, but the person does not need a rapid sequence induction intubation. What will be your muscle relaxant of choice? You will obviously avoid scoline or suxamethonium. In this scenario, the muscle relaxation of choice will be obviously one of either atracurium or cisatracurium, because they are organ independent elimination, but they're slow in onset, so not a candidate for rapid sequence induction intubation. You have a scenario, again, potassium is high, but this person needs, like one of our poll question, needs rapid sequence induction intubation, then what muscle relaxant will you go for? The answer would be rocuronium. 1 milligram per kg. Rocuronium, though, has liver metabolism, but some of it is excreted renally, so the duration of action of rocuronium will get increased. Reversal with rocuronium nowadays, not for us, but in the West, is with sugammadex. Sugammadex is typically avoided, but if you have given sugammadex, then it might have to, because it's such a huge molecule, you have to dialyze and remove it. Which is better for maintenance? Is it intravenous or is it inhalation? I think it's very intuitive, because inhalation is eliminated through expiration. Inhalation agents possibly are the more suitable ones for maintenance. People have talked about the renal toxicity of sevoflurane, and I think this examiners love to kind of grill students on this. I don't know why, but about this formation of compound A, only seen in rats with low fresh gas flow, high temperatures, not demonstrated in clinical practice in humans. About opioids, short-acting opioids are the ones to go out and avoid the long-acting opioids. Reversal neostigmine remains just like what it was even without end-stage renal disease. About sugammadex, we talked about it. Fluids, I think this is something which is very confusing. Do you use crystalloid? Do you use the potassium-based crystalloid? Should we use only normal saline? What about dextrose? How much to give? I think it has to be very, very individualized. You cannot have a blanket answer to this. Hyperkalemia, when they are NPO, the go-to fluid should be glucose. Avoided obviously in hyperglycemia, or if there is hypokalemia, the glucose fluids. And typically, like if they're coming in for a procedure, you are going to check for potassium values, check for glucose values. If they're in intensive care, they would check for potassium values, and whether you're going to give a crystalloid with potassium or not will be dictated by that. Post-operatively, it will also depend upon the attended, what has been the type of surgery, what is the associated comorbid conditions, whether they go to an high dependency or an intensive care. When is the dialysis going to happen? Again, preferably after 48 hours. All these decisions, again, has to be a collective decision. If they become something that the pH is going down, potassium is rising, and you have to go in for a dialysis, if you have and they're hemodynamically unstable, then the go-to would be continuous renal replacement therapy. That is, I think, a complete different area of interest altogether. Post-operative pain management, multimodal, but avoid NSAIDs, avoid long-acting. Paracetamol can be given. Regional techniques preferred until and unless there is no coagulopathy. And short-acting IV PCA fentanyl can be very, very useful in this group of patient population. So I will finish with the answers to the poll questions. So end-stage kidney disease, twice a week hemodialysis, and needs to come in for a gallbladder surgery. What should be the timing of surgery? I think we discussed this. Ideally, the day before or the night before. So admit the day prior to surgery, dialyze. You don't, because you're going to wait for more than 4 hours. Dialyze with heparin. That's a more efficient way of doing it. Check, try and check, do a potassium after the dialysis, should be less than 5.5. Proceed for surgery the next day is possibly the most preferred approach. I think most of you got it similar to what I thought. Not true for peritoneal dialysis. It does not lead to hyperglycemia. It leads to hypoglycemia. The rest of it is true. I think this, everybody got it nearly. So you need to have rapid sequence induction intubation. Potassium is high. ECG shows peak T waves. The go-to muscle relaxant will be rocuronium. Cisatracurium, atracurium, you will not be able to do a rapid sequence within 60 to 90 seconds. Now, this is about bleeding diathesis correction, the preferred approach. This is urgent obstructive hernia. You don't have much time. The best would be dialyze without heparin, wait for that 4 hours. You don't have to wait for the 4 hours because you need to go in possibly early. And then the go-to drugs would be desmopressin, cryoprecipitate, and maybe platelets. And non-urgent hernia surgery, you want to build up the hemoglobin in a person who is not iron deficient. The go-to approach would be the erythropoiesis stimulating agent. Target the hemoglobin between 10 to 11 or 11.5, and then admit for surgery and do this planned surgery. Thank you very much.